Dr. Meshari will talk about non-cirrhotic portal vein thrombosis, review of management, and transplant indication. Floor's view.
Thank you very much. I would like to take the chance to thank the SASOL for inviting me and the organizing committee. Thank you for the moderators. I hope I can stick with time. Beautifully done in exactly 15 minutes. I'm not sure I'm going to do that in the same time in this beautiful morning with this a lot of expert in the floor. So I'm going to move forward quickly, so I have nothing to disclose. We'll talk about main clinical presentation, investigation, treatment, some prophylaxis. We're going to walk through. So in general, portal hypertension, you know, in pediatrics, we know these definitions, well known in the adult world more than us. The problem is the measurement, and to do it invasively in children is a very tricky part. And that can be very challenging for pediatric. We usually do it when we're doing something else. So we measure the wedge pressure, and then we speculate the portal vein pressures. So in general, we talk about the entity of non-cirrhotic portal hypertension, meaning you have a normal liver function. And in developing countries, we know this is highly more noticed than developed countries. However, it has better mortality. Categories are three. We're going to talk mainly about the first one, which is the extrahepatic portal vein obstruction. Non-cirrhotic portal vein thrombosis carries the second one, and then the third, which is we love to talk about it in pediatric, we see congenital hepatic fibrosis. So without further ado, so usually it's the presentation of such extrahepatic portal vein obstruction is quite mild and sometimes very subtle, and it goes unrecognized in the beginning of life, with many factors contributing to it. So it starts usually at a mild febrile illness, sometimes in older children, or sometimes asymptomatic from the beginning. We know the thrombus organizes, then the obstruction to try to be bypassed by other collaterals, and we have a well-established cavernoma in about 3 weeks. And then usually the adjustment is not enough, and you're going to get portosystemic problems. So this is in summary. So we know that many papers talked about the location of it, and mainly in the portal vein. Sometimes it expands to the portal vein and the splenic vein and the superior mesenteric vein. Most commonly is the 70% of the portal vein alone. If you do a liver biopsy in these cases, usually you have just mild periportal fibrosis with no signs of hepatocyte injury. And the clinical features, actually the main common presentations, especially usually in developed or developing countries, has been well shown in the literature. Usually it gets identified in developed countries early on before developing the upper GI bleeding by an average of 3 years, which is quite interesting when you look at it from a kind of a presentation. Usual presentation about 6 years, give or take, to 9 years when they present with you. Usually it's a variceal bleed in developing countries, but in developed countries, usually you measure it when they present with hypersplenism. As you know, sometimes we got these cases from the hematology clinic when they are after the bone marrow getting done, and then suddenly they realize it's not caused by that, it's actually caused by the hypersplenism. And usually there is a history of mild febrile illness. And usually when you do the exam, sometimes they present with only mild splenomegaly. Sometimes we know these cases when they are presenting with huge splenomegaly affecting their gait, and they cannot walk well with it, and their growth is quite affected. And then when you start suspecting such cases, usually ascites is not a usual feature presentation, but it is mildly can be seen there. This is in the Italian paper that Dr. Ashraf actually presented in the postgraduate course, and they talked about, you could see on your right, the hematological causes or the contributing factors for the etiology of portal vein thrombosis, where you have a prothrombotic causes mainly, and then you can see the prematurity in our pediatric age group carries the higher risk, and most likely because of the infections and the use of the This little rascal down here, which is the umbilical vein catheter, which carries a future problematic event in the future, that you don't see it right away. So when they talk about acute and chronic portal vein thrombosis in the adult ward, we usually don't see it as much that way. It comes in with complications later on, especially with this umbilical vein catheterization. So another study with 200 patients, where they even realized that neonatal omphalocystis and umbilical vein catheterization with iron peritonitis can be contributing factors. Where the age of presentation, again, in most of the cases, happens in the first 16 years of life, and usually with average with 6 to 9 years of age. And all these 200 patients had normal liver biopsy, fitting the narrative of what we talk about non-cirrhotic portal hypertension. So growth failure and quality of life is the major problem in these cases, and always we see them happening with a big spleen and a very growth problems. And this could be contributed to many causes like malabsorption of portal enteropathy and chronic anemia, and then this is something called growth hormone resistance. It affects really the quality of life, and that usually pushes us to do more for these cases, more than just managing them symptomatically in the beginning. And a very good literature talking about improvement with shunt surgery in growth. So without further ado, we'll talk about the endoscopic, because I think time is running really by very quickly. And we know how the evidence of esophageal varices with time can be seen in 1, 3, or 5 years, as in many papers talked about it. And we talk in pediatrics that we use EVL, which is the endoscopic variceal ligation endoscopic sclerotherapy. And as we know now is the problem, we are staying away from EST more with EVL because it has better improvement and better outcomes. So less complications, less strictures, less esophageal ulcers. The problem is that the size of the scope. Pediatrics, again, adults don't have these problems. We have it. In less than 2 years, you cannot stick an EVL in a tiny kid, less than 10 kilos, which is very problematic. And then we have to stick in with EST. Now, many centers have tried to talk about starting with EVL and then sticking with EST. And this has been replicated in many centers in Asia and some Europe centers, and maybe Professor Kari can shine a light as well as that. The problem you have with you use more sclerotherapy, you have this motility with these cases especially. And as we know, so this is the comparison between the two, group 1, EVL and EST. So you start with EVL and go on EST, and the group 2 is EST alone. And you could see the differences in these two, so fewer sessions and even in the follow-ups afterwards. And the problem we have as well, once you finish from doing few sessions of EVL, then you go into the gastric varices, which can be a problematic thing afterwards in the future, and you could see that with increased evidence of gastroesophageal varices, and would develop more and more. So 6 minutes, and then running through. And the management of gastric varices can be very challenging. You know, most of the pediatric gastroenterologists have trouble. Not all of us are very well trained in giving glue for gastric varices and managing it. As we know, and adults know, the problem with using EST and in gastric varices, the ulcers, rebleeding rates are very high, and the glue were not very well. So we call our adult colleagues to help us out with the big chunky ones, especially in the fundal varix, or sometimes it goes all the way to interventional radiology and using some coiling as well. So this is just a guideline for usually pediatrician we use, and you try to do in an unbleeding or bleeding site, and then you try to grade your varices. You see what the best option for them for portal gastropathy or esophageal varices alone. And as we know, once you do the variceal banding, the gastric portal hypertensive gastropathy will be more evident, and that has been clearly displayed in the literature. So you will have more and more of the gastropathy. The blood diverts to the stomach after you band these esophageal varices. On the long run, you have the portal cavernous cholangiopathy, and it speaks for itself. Usually it comes in from the obstruction or comes in from the varices that can cause some portal or biliary obstruction, which can be very problematic on the long run. We don't see it much in pediatrics. However, in the long term, usually we see it. And the age group, as you can see, the more and longer years, so 14 years of age, and they can present with usually biliary strictures, which is more evident, and upstream dilatation, to speak about such cases. And there is a very good recovery and response to surgical shunting. And so this is very problematic. And as we know, in pediatrics, we have a very hard time sticking in an ERCP scope in younger children. As you know, in the NASPGHAN guidelines, they talk about 17 kilos, and you could stick this big chunky scope down their throats, and that can be very problematic. The only ones that we can do actually are the ones with the lower biliary stricture that can be accessed. So again, these cases usually depend how symptomatic they are and how significantly they're presenting. And usually shunt surgery does a very good job at this. Usually the ERCP can have a limited role in such cases. Portal colopathy has been established complication. You see it more with portal vein obstruction than cirrhotic patients, and it presents like colitis or vascular lesions. And usually the standard of care, we do the colonoscopy and assess for those if you can manage to get fewer endotherapy sessions. However, the best thing to do about these cases, some centers, if they're not surgically ready, then beta blockers can be helpful in these cases in children. Some of the complications like minimal hepatic encephalopathy and ascites. And this is the problem with portal hypertensive enteropathy, which causes growth failure in our cases. So this is unique to pediatrics. And so as you know, once depends on what you do. So usually the more you do endotherapy, it doesn't take the risk of rebleeding. So at 11% at the best, if you do your job really well and good sessions afterwards, your rebleeding risk is very high, as you could see. So you go for shunt surgery, and we do it for refractory variceal hemorrhages and symptomatic hypersplenism and specific gastric ones that are very amenable to endotherapy, and poor quality of life as well from huge spleen. So depends on how you do your access and surgically, and you do either the more anatomical friendly in pediatric, which is the Brex shunt from superior mesenteric vein to the recess, and your standard of care, the portosystemic shunts with different anatomical availability that you can do this. The problem we have with this, you have a different centers, different expertise who is an expert to do certain ones. So I'll go over this in 2 minutes, and hopefully I'll be finished by that. But usually in portosystemic shunts, we like the ones, with good spleen. So if you have a huge spleen, it will guide you toward the portosystemic shunt surgery, the regular ones with splenectomy. Otherwise, the standard of care in Vabinu, even 7 guidelines, they talk about in pediatrics, they had a line there going with mesorex shunt, which is for the beginning of treatment if the patient has anatomical feasibility. And you have your standard shunting procedures depending on your expertise. So this is one of the centers that talked about it. And usually in the center, they use the central splenorenal shunt with splenectomy. Some of them, they add in some of the devascularization of the esophageal wall. And the thing about mesorex shunt here is that it really depends on your surgical feasibility. So you need to check your angiography before, CT angiography before that. You know you have your recess shunt, then you can do it. You need a really good center and a very expert person to do such thing. Otherwise, the success rate has been very variable. If you find this little guy over there, and then it is not easy to bring such thing. And then now we have some centers who are more expert. They do the modified Rex shunt to have a better access to remove the risk of rebleeding. And you can see it's not so obvious in this. Very big in me, so the failure rate is quite high, depending on the expertise of the center that does it. And This is again, the Italian study. They talked about it. So in the Italian study, when they did assess in 16 centers in Italy, you could see the mesorex shunt, about 48% of the people or the kids who had been eligible for surgical shunting, and the rest of it depend on the feasibility of the anatomy afterwards. And two more things about, so the TIPS procedure, or the direct visualization of the portal vein revascularization. So in this, it says something about the safety, but as you could see, usually it's not very obvious here, but in the post-hepatic ones, not so much of a good response for there. So you need a very good anatomical response, anatomical assessment well enough to do such a procedure. And to the last one, 0. Okay, good. We lost that. So not a lot of cases that goes usually to liver transplant. I think one of the beautiful things, and I end with this, is that, we shared a case with Dr. Shagrani and Dr. Khalid al-Nouli as well, and then we referred to them. طبعا Dr. Shagrani did not like that case to be transferred, because usually we don't transplant these cases. We get away with a lot of, with all the treatment before, but the patient was not surgically ready, and very tiny kid, 1-year-old with extra, that's the only one I think you guys transplanted, as far as I know. You have a few hundreds on you, sorry, almost 1,000 cases that you transplanted, but you could see here just 2 things. You could see here at the end that 2 of the cases, so this is only 4 cases here, and then 1 from an extra one in the literature. That's the thing that I could find. Very minimal because of the significant bleeding. That was the main causes, and one of them had very decompensated liver disease, in addition to their portal vein thrombosis. And then the 2 of them died because of recurrence of the portal vein thrombosis, making the idea about the prothrombotic causes beforehand. So the last one here, again, the primary and secondary prophylaxis, we don't have very good guidelines about it, especially in the beta blockers, not like the adults, which is more clear in the Baveno guidelines. But this is my final slide. So thank you very much for bearing with me. I've been asked to do this in 15 minutes, extra hepatic portal hypertension. This is the best I could do. So thank you very much.
Thank you, Dr. Meshari, for the wonderful talk. It's challenging to present 15 minutes, but I think you grasp most of the core knowledge in the portal hypertension and cirrhotic cause. So we'll open the floor, maybe for one question and one comment. Dr. Mansour?
Assalamu alaikum. Very nicely done. I'm impressed as a surgeon seeing our gastroenterology going deep into the surgical details. That's great. I love the presentation. It's, as you mentioned, the anatomical patency of the vessels is what the bottom line is. I get those cases very late. Every time I look at the CT scan, I find a reason not to operate because of the blockage of the vessels. One of them is a portal vein. You have to have a patency of the left portal vein and a patency of the superior mesenteric vein. Doing a splenorenal, I've done it as an eager young surgeon when I was in King Fahd Medical City. It survived for 6 months. So you're right about the center, not the surgeon. The patency needs those patients to be at least on aspirin. So she was from a peripheral hospital, had a bleeding, and I was very depressed after 6 months from patency, because she went to a peripheral hospital that did not know how to manage medically keeping this vessel patent. We use the internal jugular. Don't use jump grafts, synthetic. Don't let that happen, because as a surgeon will suffer to get there. So we use the jugular vein. It's the best vein. I'm eager to get those cases, the right referrals, the anatomically ready, looking at the CT scans. Last case was from Algeria. They approached me, same thing, and they were willing to come pay money for the Rix shunt. I went to Birmingham, that was 2010, to see the results. And the bottom line is, you can have great numbers on paper, but when I went there deep with the people, they were not happy. A lot of those kids eventually needed the transplants. So everything you do is a bridge to transplants. And I had this feeling that it's probably best in the hands of the gastroenterology, hepatology, until they need transplant. And I kept myself away as a surgeon, waiting for this suitable case. Thank you.
Thank you, Dr. Mansour. Any question? Maybe a quick question, Dr. Meshari. Sorry? Hiba? Can we get the mic there?
We try to get away with, usually we endoscopy them all the time. So this is what we do all the time. We just do endoscopy, and gladly we don't have the, you could see the recurrence of the, or the emergence of the gastric varices. Once that happens, then we are stuck, you know. But in our center, they did 2 cases with the mesocaval shunt and devascularization with splenectomy, because these are the kids, I think the thrombus was extending even a little bit to the splenic vein as well. So they tried to look from a different direction. These kids, so far, they're surviving till now. But again, you are beautifully said it. You could have said it better than a surgeon. I was afraid to talk to a surgeon about this, because if we dive deep, we don't do much. And the sizes of the veins, you know, our size of the veins are like quite tiny. So I appreciate your help. So thank you very much.
Thank you, Dr. Hiba.
Thank you, Dr. Meshari, for this amazing talk. What's your experience with rectal varices? If you find them on the CT?
To be honest, in our single experiences, I try to leave them alone until they're symptomatic. If there are symptoms, then we send them to our adult colleagues to help us with the banding. Embolization, we've done it only once, but not with a great success in that time. The literature suggests the shunt surgery is the best for these cases. Correct. And we shared a case with, again, the same case that got transplanted. The tips actually with this case helped temporarily. Eventually, the transplant had to take over. And it brings nightmares, I know, Doctor, for that same case.
Really doing all the job. Most of the time, we're coming after you. So I wanted to tell you what's going on now in shunt. TIP, in my opinion, now in the last 20 years, in pediatric is not doing much. It's out of practice. It's not paying time for you. And so it's really out. Splenorenal, we use now, like out of those, almost now we are transplanting 934 patients. We did good number of shunt. We look, if there is already a iatrogenic splenorenal shunt and it is a good size, then most of the time the surgeon cannot do for you anatomical one bigger than this. So you will end with the same result. So if the patient already having ongoing splenorenal shunt, iatrogenic, and he's still symptomatic, then there is no point of doing another one. It will be the same. So the best way is to do mesorex shunt, and especially when there is patency in the left portal vein. Mesocaval, we share one-time data with Georgetown, and they were doing, let us say, more number of mesocaval shunt. The problem, it is very long, and they ending by initiating a practice of putting a stent. And actually, in one of the cases, which is transplanted by our center, the stent migrate to the heart. So actually, they stopped the practice. You know the case. So they stopped the practice of doing mesocaval shunt. So most of the cases we did, I can say, with successful. As Dr. Mansour mentioned, the time was very important. The liver is not cirrhotic. We did biopsy. There is no ongoing splenorenal shunt. And there is patency of both branches of portal vein. And this is the beauty. You have mesorex. We are not doing splenic artery or splenic vein ligation because I think, especially most of the cases are below 5 years, you can really create a problem of infection and sepsis with time. So yes, it is a bridging, but I can tell you we have cases now 6 and 7 years post-mesorection. The only things also we learned over the year, how you anticoagulate those patients. So sometimes giving only aspirin alone for 3 or 6 months is not true. So I'm telling you now, we are keeping them in long-term warfarin, small dose, to keep their INR between 1.5 to 2. So aspirin alone for 6 months, we lost some cases, and they ending with thrombosis again, even though their thrombophilic workup was totally normal before. Thank you.
Thank you very much.
Thank you, Dr. Mohammed. Yeah. Last question.
Dr. Meshari, thank you for your talk.
Sir?
Yeah, I'm here.
I'm sorry.
It was a very fast-paced talk, so I don't know if I missed. You didn't give your verdict on primary versus secondary prophylaxis for banding. I don't know if you mentioned that.
So it's a beautiful, thank you very much. Dr. Ashraf actually presented the Italian study, the one we had, and there is variability in the centers. So 16 centers in Italy, and they're variable. I think Dr. Muhammad Ayoub, if not mistaken, also tried to grasp it in one of the papers, if I'm not mistaken. And there is variability. There is no literature supporting using certain things. So most of the people, we need to do a study on this. So thank you very much for bringing this up. Maybe this is the venue for it, that we can see the practices, the appropriate practices, what should we do. Some people, if there is not feasible interventions, they start the beta blocker and send it. Sorry? Mine? Mine, okay. So the problem I have with this, I select my cases. If I have a very huge splenomegaly, very low platelets, I know it's there, you know. You know the varices are there, it's gonna pop at some point, as seen by the literature, within 1 to 2 years. So do I wait for it to happen or not? This is like a very difficult scenario. What I do is that once I know this case is allowing me to get in an EVLN big enough, I usually start with primary endoscopy myself, and I start beta blockers early on. Some people do not usually use the beta blockers. I'm leaning forward. Even in when I did my fellowship, that was a decade ago, and the problem, nobody was using it because of the side effects of the time. Okay.
It's time. Yeah, I think we have to stop here. And I think you did perfect on time for your presentation.
But not for questions.
But you didn't count in your discussion. And
okay.
I know this is a learning session. It's only the second chapter of the pediatric program. And I think what we learn, and it's global, when you talk about portal hypertension and shunt surgery and the treatment of varices. I think next time, I give the organizer for next year, I give into consideration 5-minute presentation, 15 minutes discussion.
Perfect.
Thank you very much.
Thank you.
Thank you very much.